Okay, we're going to do a little bonus here. We're going to talk about steroid contraception. This is not in the notes, but I think it will be helpful. One of the challenges and one of the struggles that I have is what to put in and what to keep out when we only have a limited amount of time. But this looks at steroid contraception. And what we have here is combination oral contraceptive pills, progestin-only oral contraceptive pills, progestin-only injectable, and the progestin-only subcutaneous implant. So those are really the four kinds of steroid contraception that we have. Now what we will look at is what is the active ingredient, what is the route of administration, what is the duration of action, what are the side effects, and what is the failure rate. So let's start through here. The only one of these modalities that has both estrogen and progestin is the combination oral contraceptive pill. That's the only one that has estrogen and progestin. All the rest have progestins, whether it's the oral contraceptive pill, which has a variety of different ones, whether it's the injectable, which is the Depo-Provera or depomedroxyprogesterone acetate, the DMPA, or the Norplant, which is a subcutaneous implant, and it uses L-norgestrel. But these three, whether it's the oral, the injectable, or the subcutaneous depot, those all have progestin only. Now there are some significant ramifications of that. The estrogen and progestin, and the progestin only, are the oral route. This is sometimes called the mini pill. The mini pill. Now the difference here is how often they need to be taken. The progestin-only injectable, the Depo, is given IM, and the implant is subcutaneous, usually under the skin of the upper arm, the inner upper arm. Now how long is the action, the duration of action? The combination or OCP and the progestin only are daily. They've got to be taken every day. Now, the combination typically has 3 weeks on the hormones and 1 week off. So you can have the progestin withdrawal. But the other ones, the progestins, are given daily, continually. There's no time off. They're given all the time, daily, continuously, and they need to be given at the same time, really, every day. The injectable, the Depo, is good for 3 months. So it has to be repeated. It needs to be repeated in the winter, spring, summer, and fall. Isn't that romantic? Every 3 months. How long is the Norplant good for? 5 years. Now, the side effects. The combination OCP has predictable bleeding. This is the only one that has predictable bleeding. What do the others have? Irregular. And this is one of the main reasons why women will stop using these, is because they want to have some predictability in their lives. They don't have to be wearing a pad all the time. See? And the reason for the predictable bleeding is because you have progestin withdrawal. These other ones, you don't have progestin withdrawal. And what often happens is you get atrophy from the progestins. And in fact, what is the mechanism of these steroid contraceptives? How do they work? They suppress gonadotropins. Now, if the FSH levels are suppressed, what's going to happen to the estrogen level? It's going to drop. And one of the side effects, I didn't have enough room to put it on here, of these two is there's a concern about osteoporosis and thinning of the bone, particularly in young women. Now, that is often reversible, but it comes because of the low estrogen. See? So you have an atrophy, and that's what causes the irregular bleeding. The failure rate is probably one of the best advantages of the steroid contraceptives. The combination pill is quoted about 2% failure rate. The progestin-only OCP is 3%. But look at these others. The Depo and the Norplant, less than 1%. Extremely effective. Highly effective. In fact, when you look at all contraceptives, these are probably the most effective of all of them. And this is basically, I think, what you should know in terms of the steroid contraceptives. Now, how soon can you reverse? Depo-Provera, if you give a dose, for some women it'll last for 12 months. They won't have a period for 12 months. So if a woman says, I want to put off pregnancy for maybe 3 to 6 months, don't use the Depo, because she may not have a period for another month. The Norplant typically will reverse very quickly, because it's not a Depo. You take out the rods, and there's no more which is being excreted. And of course, the progestin only, the OCPs, they will usually within 1 to 2 months. So these are really short acting, but the Depo can be a long time before you start to conceive again. Yes?
For those who skip the oral pills,
okay, if she should skip the combination pill, how long does it take for the gonadotropins to come back? It takes quite a few days. So all you say is double up, and that's okay. But with a mini pill, the progestin only pill, if you skip a day, how long does it take for cervical mucus to turn back to thin and watery? I mean, that's much more. You don't want to miss a day on those. To double up isn't going to help. Often they'll say use a backup measure until you have your period. There's a question here. Contraindications. The basic contraindications are estrogen. So the contraindications that you read in the package insert are basically for the combination pill. And those have to do with the estrogen effect on blood clotting, thrombosis, DVT. If there is active liver disease, because you could have problems in excreting. And if there is a hormonally dependent cancer, such as breast, endometrium, and melanoma is also one of those. So those are really the three main contraindications.
Is there any advantage of progestin only for oral contraceptive? Because looking at that, there is no real advantage.
The advantage of the progestin only is really here. Of the pill, see, if there is, let's say, a history of migraines, for instance, the risk of stroke in a woman with migraines is increased with combination pill, but not with the progestin only. And if she has a history of DVT, then she should not be on the estrogen, but the progestin would be okay. I'm sorry?
The morning after pill.
Oh, the morning after pill. The morning after pill is really not a pill. It has now been released under the name... No, it's released under the name Plan B. If Plan A fails, where do you go to? Plan B. This is right. It's called Plan B. And what Plan B is really norgestrel. You take 2 doses, 2 pills, and then you repeat it in 12 hours. And that's basically your morning after pill. 2 doses, 12 hours apart. Okay. Let's continue now with our regular scheduled soap opera. Okay, in terms of smoking, if a woman is smoker and is age 35 or greater, it is more hazardous to be on the combination pill than to be pregnant. So it's contraindicated in a smoker who is age 35 or greater. A younger woman, I can't think of any good reason to smoke anyway, but a younger woman who is a smoker, the risk isn't as high. But older women, it's worse to be on the combination pill than to be pregnant. Okay, case 24-year-old with long duration male pattern hair. Male pattern hair. 24-year-old gravida 2, para 2, comes to your office complaining of excessive dark, coarse hair growth on her face, upper lip, chest, pubic hair. There are many women who have far more hair on their chest than I do. I was just not given that genetic gift by my parents. And on the chest, it's really not that big of a thing because you can wear clothes. But if you have to shave, because you have such hair on your upper lip and face, it can become a social problem. Gradual onset of puberty of long duration. This is important. What if it was sudden onset, no family history? What do you think of? Tumor. Gradual onset, long duration is more likely going to be not a tumor. Mediterranean descent. Women who come from Mediterranean descent have more hair follicles per square millimeter of their skin than do whites, and particularly Asians. Asians can have very little. A full beard in an Asian man may be 3 hairs. And that's just the way things are. Okay? Mother and sister have similar complaints. Regular 30-day menstrual cycles, LMP 2 weeks ago. She's had 2 babies, normal cycles. Does she have polycystic ovarian syndrome? Probably not, because that's one of our differentials. Denies recent change in her weight, lowering of her voice, or increase in acne. Now, what would these suggest? Lowering of her voice, increase in acne. High levels of androgens, see, particularly in virilization. On exam, she's 65 inches, 135 pounds. Is she obese? No. Normal breasts and body contours. On exam, dark terminal hair on her upper lip, anterior chest and back. Pubic hair triangle is inverted with dark hairs in the midline. Her clitoris is not enlarged. That's important, because if you have a tumor, very high levels of androgens, you can have enlargement of the clitoris. Okay, differential diagnosis. Androgen-producing tumor of what areas of the body make androgens? Adrenals, ovary. So when we look at a tumor, it could be adrenal tumor, it could be an ovarian tumor. Polycystic ovarian syndrome. Congenital adrenal hyperplasia is unlikely, but that can occur. Hair follicle sensitivity. More than likely, this is where we're going to end up, right here. Let's talk about it. So our plan, there are 3 medications or 3 blood tests we're going to get. A serum dihydroepiandrosterone sulfate. We're going to get a serum testosterone, and we're going to get a serum 17-hydroxyprogesterone. DHEAS is produced almost 100% by the adrenal gland. If you have an adrenal tumor, that will be elevated. Testosterone is produced by both the ovary and the adrenal gland, but is basically an evidence of an ovarian tumor if it is markedly elevated. With polycystic ovarian syndrome, you can have mild elevations of testosterone. 17-hydroxyprogesterone is a precursor of cortisol and occurs with 21-hydroxylase congenital adrenal hyperplasia. 17-hydroxyprogesterone is an androgenic steroid, and that can be elevated with congenital adrenal hyperplasia. In this case, what do we find? DHEAS, normal. Testosterone, within normal female range. 17-hydroxyprogesterone, normal. Basically, what we're saying here is peripheral androgens are not elevated. Peripheral androgens are not elevated. So where are they elevated? Within the hair follicle. Within the hair follicle. See, the final common pathway for hirsutism, male pattern, is in the hair follicle. And there is an enzyme, 5-alpha reductase. And it converts androstenedione and testosterone to dihydrotestosterone. And why is that important? This looks at the relative androgen potencies of DHEAS, dihydroepiandrosterone, androstenedione, testosterone, and dihydrotestosterone. You can see the weakest of these is DHEAS and DHEA. The most potent is DHT, dihydrotestosterone. And if we convert androstenedione to dihydrotestosterone, we have increased the potency 20 times. And that's all 5-alpha reductase. See, that's what happens in the hair follicle. So you can have normal levels in the peripheral circulation, but if in the hair follicle, that's what's happening. That can do the dirty work, so to speak. So, in this situation where you have normal levels of DHEAS, normal levels of testosterone, and normal levels of 17-hydroxyprogesterone, you're basically left with hair follicle sensitivity and elevated 5-alpha reductase enzyme activity. So what we want to do is to use a medication which will suppress 5-alpha reductase. Spironolactone will do that. Now, it's a potassium-sparing diuretic, but its side effect is to suppress. And it can do that as an androgen receptor blocker, but also 5-alpha reductase enzyme reducer. Now, there are 5-alpha reductase enzyme inhibitors which are available. What are they called? Finasteride, Propecia. Okay. The problem there is, what if she is pregnant and you expose the fetus? And so that's why they don't like to use that in women, although it should work very well. So, in summary, what have we said? DHEAS, testosterone, 17-hydroxyprogesterone. If there is a tumor, either an adrenal tumor or an ovarian tumor, what is the history going to be? Virilization, rapid onset. So if you have a case on the exam, rapid onset, no family history, virilization, clitoromegaly, loss of breast contours, lowering of the voice, frontal balding, that's going to be a tumor until proven otherwise. And how do you treat a tumor? Surgical removal. Okay, then you have testosterone mildly elevated. That's in PCO. And polycystic ovarian syndrome is classically hirsutism, infertility, and obesity. There's also insulin resistance and things. But your history is going to be gradual onset. How do you treat this? The problem here is you don't have the increasing levels of estrogen which result in the LH surge. You have a tonically elevated level of LH. What does LH do in the ovary? It stimulates the theca cells to produce androgens. See? And so those are constantly being produced. How can we suppress the gonadotropins? Oral contraceptives. The oral contraceptives work with PCO in two ways. One is they suppress the gonadotropin stimulation of the LH. Secondly, they increase the sex steroid hormone binding globulin. And remember, the active ingredient is going to be the free androgens. So if you increase the binding, what will happen to the free androgens? Decreases. So two ways. It suppresses the LH and the gonadotropins, which stimulate the androgen production. And secondly, it increases the sex hormone binding globulin, so it decreases free androgens. That's a PCO. 17-hydroxyprogesterone, if that's elevated, congenital adrenal hyperplasia. Typically, it's going to be gradual onset. How do you treat any congenital adrenal hyperplasia? Glucocorticoids. What will happen? The precursors will go down. And if you have idiopathic hair follicle, that's where you have the dihydrotestosterone is elevated, but in the hair follicle, you won't pick that up in the peripheral blood. And the treatment for this, we said, was spironolactone. Now, the hair which is already there, what are you going to do? Shave it. Electrolysis, burn it. Wax it. Pull it. Laser. Tough. Okay. Questions on that? Well, finasteride is not currently approved for women.
But if the only concern is the pregnancy, then we can use it because we can rule out pregnancy.
Okay, the question was that if you could rule out pregnancy, why not use it? Scientifically, you're correct. I wouldn't put that down on the exam.
I don't know the exam, do you have to follow up the potassium? Do you have to be able to, because they will spare the potassium.
You could, if you have high doses. Typically,
With the spironolactone you are saying,
yes.
you follow up with the potassium,
Spironolactone, how do you usually follow up with spironolactone?
check the potassium.
Then I would check the potassium. Okay, I'm going to move on because we're going to have some cases which we're not going to cover here, I'm afraid. Some of these are pretty quick. A sterilization, 30-year-old requesting sterilization. Multipra comes to the outpatient clinic requesting permanent sterilization. She has 5 healthy children. She and her husband have discussed the issue at length. They both agree they've completed their family. They've discussed multiple other forms of birth control, are unwilling to try them. Her last period was 3 weeks ago. General physical exam is unremarkable. Let me tell you this. If it's even Steven, they just don't want any more babies, it's not a woman thing, it's not a man thing, what should be done? I'm going to be judgmental here. Gentlemen, step up to the microphone and say, honey, you've done your part, I'll have a vasectomy. It's cheaper, it's outpatient, it is highly effective, and there is objective evidence of success. In a female sterilization, you don't have that. It's inpatient. It's going to have to be in the operating room. It's going to be general anesthesia, at least, not a local anesthetic. And you don't know if it worked. All right, having said that, let's go on to the case here. Beta-HCG. Make sure she's not pregnant. And we're going to discuss other alternatives, which are reversible contraceptives. Counsel the patient regarding the permanent nature of the procedure. A tubal ligation should be considered permanent and irreversible. It's not that it is always permanent, because you can have a failure rate of 1 in 200. It's not high. You know what the failure rate for vasectomy is? 1 in 400. So it's twice as effective. And how much does it cost to reverse a tubal ligation? $10,000 to $15,000. And there's no insurance that I know that's going to pay for that. And then bring the patient back in a month for a tubal ligation, preferably after the menstrual cycle, and be counseled on the increased risk of ectopic pregnancy if she has a failed tubal ligation. This is an interesting slide because it looks at the total cost in terms of the procedure, related side effects, and unintended pregnancies of various forms of contraception. And what you see on this end is cervical cap, sponge, female condom, spermicides, diaphragm. Basically your barrier methods. Down on this end, what do we have? Copper IUD, vasectomy, implant, which is your depot, injectable. No, implant is a Norplant, injectable is a depot. So these are your more effective ones. But what I want to direct your attention to is a female tubal ligation and vasectomy. Cost-wise, I mean, there's no comparison. All right. This you probably should be aware of. A woman has a tubal ligation and then says a little while later, darn it, I wish I hadn't had it. What are the risk factors for regret? This is not in your notes. If she is young, less than 30, if she has medical indications, heart disease, diabetes, some medical reason why pregnancy would be hazardous to her, but she's got her heart pulling her in both ways, right? Recent emotional trauma, divorce, death. Let's say she had a stillbirth. She had a neonatal death. I will refuse to do a tubal ligation on a patient like that because she hasn't dealt with her grief. When she gets over the grief, what's she going to do? Oh, I think I'd like to have another one. I'm sorry, you're fixed. You know, too late. Coercion. Coercion. That's going to be a risk factor also for regret. Okay, questions on sterilization. All right, next topic. 35-year-old with post-coital bleeding. 35-year-old presents to the outpatient clinic with postcoital bleeding. The bleeding has occurred sporadically over the last few months, but in her last few weeks has increased in frequency. Postcoital bleeding. You've got to think of some cervical lesion, right? Not a hormonal, not an intrauterine problem. Her regular periods have not changed in character. She has a history of PID in the past, as well as multiple sexually transmitted diseases. General exam unremarkable, but speculum exam shows an ulcerative cervical mass. I don't like that. Parametria lateral to the uterus are fixed. Rectovaginal exam, guaiac negative, but an extrinsic mass is pushing on the rectum. Cervicitis, HPV, endometriosis, cervical dysplasia, no. Cervical cancer. 35-year-old with cervical cancer? Could that be? Yes, it can. It is the earliest of all the gynecologic cancers is cervical cancer. The earliest. Complete blood count, she's bleeding. Serum BUN creatinine. Why are you concerned about BUN creatinine? What is the commonest cause of death in cervical cancer? It's going to be ureteral compression from the tumor, which causes then renal failure. Cervical biopsy must be your key here. Cystoscopy, is there any bladder involvement? Proctoscopy, is there any colon involvement? IVP to see, is there any ureteral involvement? And what do we find? CBC, normal. BUN creatinine, ouch. Markedly elevated. Cervical biopsy, invasive cervical cancer. Cystoscopy, normal bladder, but an extrinsic mass at the site of the left ureter. Proctoscopy, no extrinsic mass. IVP, right ureteral compression with hydronephrosis. This is advanced cervical cancer. How do you deal with this? Basically X-ray radiation. Chest X-ray to make sure there isn't any lung metastasis. CT of the abdomen and pelvis to see if there's any further metastasis. Chest X-ray is normal. CT, positive inguinal and retroperitoneal nodes. What stage is this? This is at least stage 3. Getting to stage 4 if you've got abdominal nodes already. This is external beam radiation. Invasive cancer. The definition is the basement membrane is penetrated. Presentation most commonly is postcoital bleeding. The mean age of diagnosis is 45, the youngest of all gynecologic cancers. You must do a biopsy and then a metastatic workup. This is basically what happens with cervical cancer. Initially, you have dysplasia. Dysplasia is within the epithelium. It is intraepithelial. As the basal cells thicken and involve more and more of the epithelium, when you get full thickness, it is carcinoma in situ, but the basement membrane is still intact. But once these cells start to invade, you've got invasive cancer. And I don't think this is worth filling your brains with. But you can have minimally invasive, less than 3 millimeters thickness, microinvasive between 3 and 5 millimeters, and then frank invasion over 5 millimeters. And the risk of metastasis goes up with each of those. Once you get more than 5 millimeters, you're going to have to do radiation therapy or radical hysterectomy. In this woman, you can't cut it out. It's gone too far. It's radiation therapy. Staging of cervical cancer. I'll just show you this, but don't memorize it. This is the pelvic side wall. Would you like to see the cervix? Here's the cervix. How about the uterus? Here's the uterus. And maybe a vagina. There we go. How about tubes? Here's some tubes. And here's ovaries. Some people have said, it looks like a reindeer. I guess it does. Okay, stage 1 cervical cancer involves only the cervix. Stage 2, the proximal vagina and into the broad ligament, but not out to the pelvic sidewall. Stage 3, the distal vagina or out to the sidewall. And this woman has at least that, because she's got ureteral compression. And then distant metastasis is stage 4. And your survival goes from stage 1, 90%. Stage 2, can't see it here, is going to be about 60%. Stage 3, maybe 40%. Stage 4, 20%. So staging, it will give you your prognosis. Okay, questions on that? We don't see this very often because we have pap smears. Pap smears. Now, if only we had as good a test for ovarian cancer. We don't have it. We just don't have it. Okay. 65-year-old woman with low back pain and vaginal pressure. 65-year-old woman calls the outpatient office complaining of low back pain and vaginal pressure sensation. Think you should send her to the orthopedist for back pain? It's interesting. Pelvic relaxation will often show up as back pain. She's had 5 spontaneous vaginal deliveries. One of the risk factors for pelvic prolapse is many babies. There is even now suggestions that maybe women should be offered the opportunity to have elective cesarean and protect their pelvic diaphragm. That's controversial. But look at this woman here. Her largest baby was 9 pounds, 11 ounces. Whoa! And she pushed that baby out. Denies history of urinary or fecal incontinence. Now, why is this important? Cystocele, you could have urinary incontinence. Fecal incontinence was, well, not usually with erectocele. She's been on hormone replacement therapy, estrogen and progestin. General exam is normal. Pelvic exam, normal external genitalia, but she has second-degree cystocele, second-degree rectocele, and uterine prolapse with evidence of an intracele. She's got everything that she doesn't want. Uterus is normal size. The adnexa are normal. The right rectovaginal exam is confirmatory. All right, what are we going to do? Pap smear if not done within a year, and that looks okay. All right. Our assessment is cystocele, rectocele, intracele. Treatment. When you have the degree that she does, medical management probably not going to do anything. You're going to have to do surgical treatment. The uterine prolapse, total vaginal hysterectomy. The rectocele and cystocele, anterior and posterior vaginal wall repair, and intracele is basically resection. And it's really a surgical treatment. Is this life-threatening? No. If you're living in our country to the north, Canada, they'll put you on the waiting list, and we'll do it in a year or so. I was just talking to some of my relatives up there. But this is something which can be done electively and usually can be done successfully. This is a picture of a cystocele. And you can see here the anterior bladder wall is prolapsed through the vagina. This is an enterocele. And this contains a small bowel. And here's a rectocele, and this contains the rectum. And it comes down posteriorly here. If a patient is not a surgical candidate, you can use what are called pessaries. And there's all different kinds. This one has a string here to make sure it doesn't get lost. This one is inflatable, like a donut. And this one here works kind of like a plunger. And this is how it's put into the vagina. And it holds the uterus into a more anatomic position. The definitive treatment is really a colporrhaphy, where you open up the mucosa and dissect underneath, get the fascia, and bring the fascia together, and that's what gives it the support. And if it's anterior, then you would do an anterior colporrhaphy for the cystocele. If it's a rectocele, you do a posterior colporrhaphy. Any questions on that? Pretty straightforward. Pelvic prolapse. The main risk factor is babies, too many babies. Everything which is natural is not necessarily optimal. All right. 50-year-old with irregular bleeding, then amenorrhea. 50-year-old, last menstrual period, 3 months ago, comes to the outpatient clinic concerned about 2 months of irregular bleeding and amenorrhea. So she had irregular bleeding and now amenorrhea. Has hot flashes, difficult to live with, depressed, angry, easily agitated, sex is no longer enjoyable, frequency and dysuria. On exam, flushed features, irritable, dry vaginal mucosa. What's going on here? Pregnancy? Could she be pregnant? 50-year-old could be pregnant. Now, the likelihood of carrying it to a term is... But amenorrhea, you've got to think of pregnancy. Menopause or perimenopause would certainly be part of it. Dysmenorrhea, probably not. Menopause sounds more like this. What's our plan? Well, let's rule out pregnancy with a beta-HCG. That's pretty easy to do. Now we need to look at, is this menopause or perimenopause? What is the definition of menopause versus the definition of perimenopause? Menopause is a retrospective diagnosis after 12 months. Perimenopause is a period, maybe 3 to 5 years preceding menopause, where you can have increasing or decreasing levels of hormones. Follicles respond and then sometimes don't respond. So you really need to say 12 months of amenorrhea. Now, let me just show you some pictures here. Serial FSH levels, 2 weeks apart, if they are elevated, is consistent with menopause. See, FSH is going to respond inversely to the estrogen level. If estrogen levels are low, FSH will go up. So we make a diagnosis hormonally by persistent FSH levels, and the management is counseling, what's going on. If she has a uterus, which she does, estrogens. We want to protect against endometrial hyperplasia and potential endometrial cancer by giving her progesterone, so estrogen and progestin, and these are given simultaneously, daily, without the off and on. And after 3 months, she'll stop having any menstrual bleeding at all, and then check to make sure that everything is okay there. So the main thing is, if you're going to give estrogen, hormone replacement therapy, if she has no uterus, only estrogen. If she has a uterus, she needs estrogen and progestin, and that is usually given simultaneously and continuously. Estrogen receptors are everywhere, in the brain, in the heart, blood vessels, in the bone, in the skin, in the vagina, and menopause is basically an estrogen deficiency. This is looking at menopause. Menopause occurs when the follicles are gone. A female newborn is born with 1.5 million follicles. By the time she begins her puberty, she has 350,000 left. After 360 menstrual cycles, at which time about 1,000 are gone every month, there's no more left. And when they're all gone, that is menopause. The age of menopause has not changed over the last 50 or 100 years, even though puberty has become earlier. And it's, to a great degree, genetically predisposed. You can have menopause come on a little earlier if you'd like. You know how you do that? Smoke. 1.5 to 2 years earlier if you smoke. But otherwise, it's pretty well genetically determined. And when the follicles are gone, that's it. Now, the menopause then occurs earlier than we actually diagnose it. Because we say we want 12 months of amenorrhea. And the idea is the longer that you wait and there's no evidence of follicle activity, the more confidence you have that they're all gone. And we arbitrarily say 12 months, that's it. One of the big concerns about menopause is osteoporosis. This is trabecular bone thinning. It's not the cortical bone, it's trabecular bone. What are the sites of fractures? The most common site of fractures is in the vertebral column. Loss of height, up to 3-4 inches sometimes. As the spine gets curved, with not scoliosis, with not lordosis, whatever. As it gets curved, your center of gravity gets pushed forward. It's easier to trip and fall. And when you fall, you're going to put forward your hand, you're going to get wrist fractures and hip fractures. Half the women who get hip fractures will never be independent living again. And 50% will die within 6 months. You know what from? Deep venous thrombosis because of immobilization. So this is a significant issue. Now, estrogen replacement. Many women are afraid of estrogen replacement because they're afraid of breast cancer. And they say, I don't want to have breast cancer. Most women, if you ask them what they're going to die from and they're concerned about, is breast cancer. Let me show you the numbers. The number of women who died from breast cancer in 1997, the number of women who died from cardiovascular disease. So clearly cardiovascular disease is a far greater risk. Should all women be on hormone replacement? It used to be thought, if you want to be forever young, if you never want to lose that fountain of youth, you just take estrogen. No. The evidence is, what else do I have cooking here? Okay. The evidence is that maybe estrogen doesn't have all the benefits in terms of cardiovascular disease that we thought. Maybe in prevention, but if you give to women who have already heart disease, you can actually be worse off. Does estrogen trigger or bring about breast cancer? That's a big question. It is clearly estrogen related. Is it going to be increased? That information we will know in 2007. There's a randomized prospective study. Right now, the recommendations are assess for osteoporosis risk. Who is at highest risk for osteoporosis? Twiggy. Young, not young, thin, Caucasian, family history. Slim and trim. Now, your more generous body habitus woman, she has much lower risk. Why does she have a lower risk? Because her peripheral adipose converts adrenal androgens into estrogens. So she's got plenty. But because of that increase in estrogens, she has a high risk of breast cancer. The obese woman. So you kind of trade off. If she has a high risk of osteoporosis, you need to get a bone density to see where she is in terms of current bone. And then a 24-hour urine assessment of calcium loss. They call it NTX. So those two will tell you. If she's doing well, no hot flashes, she may not need estrogen. But if she's at risk and she has low bone density or losing calcium rapidly, she should be on something. If it's not estrogen, then she can be on alendronate, which is a Fosamax, or a newer one is raloxifene, or what's the trade name for that one? Anyway, yeah, it's a selective estrogen receptor modulator. I can't remember what the trade name is. Evista, E-V-I-S-T-A. And what these do, these selective estrogen receptor modulators, they are estrogen agonists in some tissues. They are estrogen antagonists in other tissues. But this is estrogen agonist in the bone, but it is estrogen antagonist in the uterus and in the breast. What's her risk for breast cancer? If she has a high risk of breast cancer with BRCA gene or family history and low risk of osteoporosis, I wouldn't take her. Cardiovascular disease, we're still looking at. Does it really prevent? So, should you be on it when you get 55? Hopefully we'll have more answers for that. Okay, how are we doing? How's your brains doing, by the way? Is it time for another break? Let's take another break. 10-minute break. Okay, this is now a 57-year-old with a simple ovarian cyst. Let's look at this case. 57-year-old postmenopausal woman is seen in the outpatient clinic for follow-up appointment. She had an ultrasound done to rule out cholelithiasis, and they incidentally found a 4.1 by 3.8 centimeter right ovarian simple cyst without septations. Now, this was a energetic ultrasound technician who, instead of just looking at the liver, said, well, let's look around a little bit. Because she was basically asymptomatic, right? Asymptomatic. No septations, no free cul-de-sac fluid. Her last period was 5 years ago. She's on estrogen and progestin hormones. Physical and pelvic exam were unremarkable. You can't even feel it. But it's there. What are you going to do? Differential diagnosis. Benign ovarian cyst. Ovarian cancer. Is she in the age group? Sure she is. Old tubal ovarian abscess. Now, let's just look at this. It's simple cyst. It's fluid-filled. There's no septations, no calcifications. What's the likelihood that this is cancer? What is the most common cancer? Ovarian cancer. Epithelial cancer. The most common epithelial cancer is serous cystadenocarcinoma, followed by mucinous cystadenocarcinoma. Now, are these simple cysts?
No.
They're partially solid, partially cystic septations. They are what we call complex. This is not complex. Old tubal ovarian abscess would be complex because you'd have bowel, you'd have omentum, you have all kinds of stuff which is packed into them. So, how are we going to find out what's going on here? What you want to do is what you would like to avoid is unnecessary surgery. CA-125. What is CA-125? It is a tumor marker for epithelial ovarian cancer. CEA is another tumor marker. This would at least be a screening test. Now, CA-125 can be elevated in pregnancy, with endometriosis, from a variety of conditions. It's not necessarily only with ovarian cancer. It's normal. Probably a benign ovarian cyst. The recommendations are, if it is a benign ovarian cyst, I shouldn't say that. If it is a simple cyst without septations, without calcifications, if there is a normal CEA, CA-125, repeat the ultrasound and see if it's changing. We did that, no change, simple cyst appears the same. Management, just follow it. Now, ovarian cancer is something to be taken seriously. In the past, this kind of thing would be operated on. What is the likelihood that a postmenopausal woman has a functional cyst? She should not have any follicles which are producing follicular cysts. She should not be ovulating. She should not have a corpus luteum cyst. So what's happening here? There must be some tissue response, but it's unlikely to be malignant. Now, what if you knew, how can I put this? A patient comes to you with a mass which is cystic, and she had an ultrasound done 2 years ago, and there's basically no change in it, what's the likelihood that that's cancer? Probably not. And in that case, it can probably be watched. So, if there's no change in the cyst after 1 year, we'll probably assume that it is just benign and no need to operate on it. Now, the next topic is more serious. 58-year-old woman with postmenopausal vaginal bleeding. What should be your concern anytime you have postmenopausal bleeding? Endometrial cancer. 58-year-old obese woman. What do you think is the relationship between body mass index and endometrial cancer? The 3 epidemiologic associations are obesity, hypertension, diabetes. Have you heard that? Yes? No? Too sleepy? What is the relationship between hypertension and endometrial cancer? I don't know how high blood pressure causes endometrial cancer. How does diabetes cause endometrial cancer? Do blood sugars do it? I don't think any of those. Here's what I think happens. Obese women have peripheral conversion of androgens into estrogens, and that's what raises the risk. The more obese a woman is, the more likely she is to have diabetes, the more likely she is to be hypertensive, but I think those two ride along with the obesity. I don't think they cause it. It's really the obesity. And this patient, we said, is obese. So she's at risk. Her last bleeding was 2 weeks ago. Menopause was 10 years ago. She had a history of infertility requiring clomiphene for ovulation induction. What does that tell you? Chronic anovulatory. So she's had long periods of time without progestins. That's associated with endometrial cancer. She's never been on oral contraceptives. What do oral contraceptives do? They suppress, and you have estrogens plus progestins. She denies history of STDs. Last pap smear was normal 4 months ago. Blood pressure, a little hypertensive, obese, hypertensive. Physical exam, unremarkable. Pelvic exam is unremarkable. Uterus is small, non-tender, and mobile. Do you think that endometrial cancer is associated with an enlarged uterus? Unless it is advanced cancer, you wouldn't expect any enlargement. So the size of the uterus doesn't tell you whether or not she's got endometrial cancer. The differential diagnosis must be, number one, endometrial cancer. What else could cause bleeding? Endometrial atrophy, endometrial hyperplasia, endometrial polyps. Let me give you multiple choice. Of women who have postmenopausal bleeding, what percentage do you think have endometrial cancer? 15%, 30%, 60%, 90%. 15%. It's really a minority. The atrophy can cause it, hyperplasia. So, but yet the most serious of all these is endometrial cancer. So I think we need to address that first. How are we going to find out if it's endometrial cancer? Will an ultrasound tell you that? Biopsy. Biopsy. Endometrial biopsy. What is the result? Complex hyperplasia with atypia. Interpret. Who's the pathologist here? Who was the pathologist? Interpret this for me. What does this look like? Is this cancer? This is the next stage. You know, in cervical cancer, where you have stratified squamous epithelium, you have a basement membrane. Carcinoma in situ is the next step before endometrial cancer. Before cervical cancer. This is considered to be just before. 30% of these, if untreated, will go on to endometrial cancer. So this is premalignant. Now, how good do you think was our sampling of endometrium with an endometrial biopsy? What percentage of the endometrial lining do you think you sample with a biopsy? Well, you think that you get all of it. If you looked at the uterus, even after a DNC, when you took it out, 50% you didn't even touch. Even though you scrape. So I guess what I'm saying is, can we say, because of the endometrial biopsy showing this, that she doesn't have cancer? No. So what we're going to do with complex hyperplasia with atypia on the sampling, we're going to go ahead and do a D&C. That will give us a better assessment. How would you diagnose polyps? Hysteroscopy. So, a D&C and hysteroscopy, well-differentiated endometrial adenocarcinoma. Now, when you look at the good cancers and the bad cancers, is this a good or a bad cancer? This is well-differentiated, so this is probably your best. This would be your best responder. Now, how do you stage endometrial cancer? Surgically. Stage 1 of endometrial cancer is limited to the uterus. Stage 1A, only the endometrium. Stage 1B is less than halfway through the myometrium, and stage 1C has gone more than halfway through the myometrium. How do you know whether it's gone through the myometrium or not? You're going to have to take the uterus out. So part of the staging procedure is going to be a total abdominal hysterectomy. So we're going to do surgical staging, exploratory laparotomy, peritoneal washing. Why do you get peritoneal washings? That's right. Is there any tumor that has gone off into the peritoneal fluid? See, one of the ways that endometrial cancer spreads is through the tube. It goes through the tube and drops down to the ovary, and one of the sources of metastatic cancer to the ovary is endometrium, and then it can go into the peritoneal cavity. So washings, TAH-BSO, total abdominal hysterectomy with bilateral subpingual oophorectomy, and then selected pelvic and periaortic node dissection. Because what we want to know is a total hysterectomy going to be enough, or do we need, in addition to do radiation therapy? So, if it is 1A, localized to the endometrium, well differentiated, and no node involvement, then a TAH-BSO is all you need to do. But if it's gone more than that, and I think your notes will describe that in more detail. Any questions on endometrial cancer? The bottom line must be you've got to do a tissue sampling. You've got to get a tissue sample.
I'm confused about the biopsy and the D and the C.
Yes. The biopsy is done in the office. It's a limited sampling only. It's done without anesthesia. A D&C is done under anesthesia and is much more vigorous.
Scraping.
And you get more of a sampling. More, it's scraping, yes.
You pick up a biopsy as a first step.
That's right. The biopsy would be your first step. What is what? Well, endometrial aspiration is where you have a hollow pipette, you put it into the endometrial cavity, and then you create a suction. And it's kind of like a little mini. But the curettage is where you have a sharp instrument and you scrape, whereas this is really just aspirating the cells which are on the surface. But if those show malignancy, then you know you don't do a D&C because you've already got your diagnosis. Now you've got to then take out the uterus and see how much it has invaded.
Isn't peritoneal carcinoma more common in ovarian versus endometrial cancer?
Yes, peritoneal carcinomatosis is more common with ovarian cancer. You're correct. But you can have shedding into the peritoneum, and if you've got a positive cytology on the peritoneum, then you know it's gone, further than the uterus. What's that?
What is chemotherapy?
What kind of therapy?
I mean chemotherapy.
Oh, chemotherapy?
For endometrium.
You're going to use progestins, because if it is endometrial cancer, progestins stabilize the endometrium. So the sequence would be a TAH-BSO. If you have more than endometrial involvement, if it's gone into the myometrium, then you're going to do radiation therapy. You may do intracavitary or localized. If it has gone beyond the uterus, then you would do the chemotherapy, which is progestins and then other agents which I'm not that familiar with. Okay. 52-year-old with a left breast lump. 52-year-old nulliparous woman comes to the outpatient clinic with a left breast lump which is hard but not tender. Remember the other case we had? It was rubbery. Hard but not tender. Menarche was age 12. Does that make any difference? What is the relationship between onset of puberty and breast cancer? The earlier, the higher the risk. Why? There is clearly an estrogen relationship here. Menopause was 3 years ago, at age 49. So really, she's really quite average. It's not that she's had extremely early menarche or late menopause. Her last mammogram was a year ago. Doesn't say what it showed. I presume it was normal. Her mother had breast cancer diagnosed at age 70. On examination, a 3-centimeter mobile, non-tender mass in the retroareolar region of the left breast. No nipple discharge, no retraction or dimpling. The skin above the lesion appears normal. So far, so good. How do you stage breast cancer? TNM, the size of the tumor, presence or absence of nodes, and distant metastasis. I think it starts out with less than 2 centimeters or greater than 2 centimeters for the size, and this would be then already a stage 2. Axillary exam on the left, few small mobile lymph nodes. What's the significance of axillary lymph nodes? If they're present with tumor, it's not good. Right breast is negative. I'll show you a picture of that coming up here. Differential diagnosis, benign cystic disease. Doesn't sound like that. It's a solid mass. Breast carcinoma would be the biggest concern. Metastatic disease to the breast from someplace else. Diagnostic plan. What's our plan? Mammography, fine needle aspiration, excisional biopsy. What's mammography show? 3.5 centimeter mass, irregular borders. Benign lesions tend to have regular borders. Tumors tend to have irregular borders. No other lesion in the breast. Fine needle aspiration, suspicious for malignant cells, excisional biopsy, invasive ductal carcinoma. What's the most common breast cancer? Ductal. Positive for both estrogen and progesterone receptors. Is that good or bad? That's good. The best tumors, in terms of response, have estrogen progesterone receptors. Assessment, invasive ductal carcinoma. Diagnostic plan, CBC, liver function tests, chemistries, chest x-ray to see if there's any metastasis, left lumpectomy, axillary node dissection. The chemistries and blood test normal, chest x-ray normal, axillary node dissection and lumpectomy. 3 of 20 nodes positive for cancer. What is the significance of nodes positive? This is looking at 5-year survival with breast cancer. The top line, negative nodes. The second line is 1 to 3 positive nodes. And the bottom line is 4 or more positive nodes. Now, what's striking about this picture is, notice the 5-year survival with negative nodes. Wouldn't you think if you had negative nodes, you'd have 100% survival? The survival, as you can see, is less than 80%. That's why breast cancer is considered a systemic disease on diagnosis, regardless of what the nodes show. So you've got to treat aggressively in spite of that. And once you have more and more nodes that are positive, it's not a good thing. So nodes do make a difference. So the treatment with the positive nodes, adjuvant chemotherapy. Did the general surgeon talk to you about breast cancer? Would they give radiation therapy as well? Yeah, I think that needs to be added here as well. Radiation therapy and what's adjuvant chemotherapy? It's basically on top of your... It's chemotherapy, which is trying to minimize the spread. Okay, any questions on breast cancer?
The pap smear, the patient did it the year before. If the patient did it, we do it pap smear for the patient. I don't see the patient. Do we have to call the patient?
Now you're talking about a pap smear.
Right. It's right here. It's in the question, right? Did the pap smear a year ago? Oh, mammogram.
Mammogram. Now let me ask you this. What is the evidence that mammography has decreased the rate of invasive breast cancer? Not very good. What is the evidence that self-breast examinations decreases the rate of breast cancer? There was a randomized, well, it wasn't a randomized, a study done in mainland China where they took 2 towns. One, they did intense education of women on self-breast exams. The other, they didn't do any education at all. And it was a 10-year study, and they hoped to show that by having women do breast exams themselves, that they would lower the rate of invasive breast cancer. They broke the code after 5 years to see if there was any difference. You know what they found? No difference. That was very disappointing. They're continuing the study, and women are still being recommended to do breast exams themselves. But we haven't done a very good job. The risk of women getting breast cancer on the average is the same as a heavy smoker getting lung cancer. Not good. Yes, sir.
One question is, if a young woman has family history, her mom has a history of CA, but if you consider hormone replacement, that's risky, right? But what about the aunt? Is it the same risk or not?
Okay, the question was the degree of relatives who have breast cancer, and would this be a contraindication to estrogen? First degree versus second degree relatives. I think it's mainly first degree is what you're looking at. Sister, mother type thing, not aunts and that down the road. Okay. Next case is a 60-year-old with abdominal fullness and ascites. 60-year-old nulliparous woman comes to the outpatient clinic with abdominal fullness, decreasing appetite over the last 4 weeks. Her waistline is expanding, but she hasn't gained weight. This is a classic story. Her symptoms are largely related to the GI tract, right? To the abdomen. So who does she go to see most commonly? The internist. What's the internist going to do? Try some antacids, maybe some Pepsid, just more symptomatic treatment. Didn't help. Last menstrual period at age 52, so 8 years ago, denies nausea, vomiting, diarrhea, bloody or tarry stools. Aunt with breast cancer, no family history of ovarian cancer. On exam, she appears well, without adenopathy. Lungs are clear. Abdomen is distended, soft and non-tender. No hepatosplenomegaly, but shifting dullness. Shifting dullness. Now, when Dr. Fisher comes, tell him my definition of shifting dullness. Internal medicine rounds. You start at one room and you talk for 20 minutes. You shift to the next room and you talk for 20 minutes. You shift. No, I'm glad that there are good internists out there. Shifting dullness, that's not a good sign. Pelvic exam, large, fixed right adnexal mass. differential diagnosis. Primary ovarian cancer, maybe a uterine mass, unlikely. Metastatic tumor to the ovary. Where do metastatic tumors come from to the ovary? GI tract, stomach. What's that called? Kuchenberg's tumor. From the endometrium, goes through the tube and comes down. My mother, that was quite some time ago now, had ascites, just like this case here. Abdomen getting large. They found bilateral ovarian masses. Took her to surgery. The ovaries were normal. It was metastatic. It was a papillary adenocarcinoma. So, where did it come from? Thyroid was normal. Well, that's the thyroid. Mammography was normal. Endometrium, did a DNC, that was normal. Upper GI, lower GI, pancreas, no, it wasn't melanoma. She died from this and never did find out where the primary came from. So, metastatic tumor of the ovary can occur. Ovarian cyst, it doesn't look like an ovarian cyst. Old tubal ovarian abscess. Now, this is a possibility. What is the screening for ovarian cancer? The screening for ovarian cancer currently is a pelvic exam. Now, don't you think that ultrasound would be better in picking up an adnexal mass? Of course it would. The problem is, and this study was done at Cedars-Sinai Hospital, down there, I think. And they looked at screening for ovarian cancer by doing ultrasound. Here's what they found. They were very successful in picking up masses, but only 1 out of 30 of the masses that they picked up and operated on were ovarian cancer. So they operated on 97% of the patients unnecessarily. And what were they picking up? Old tubal ovarian abscesses, which had just scarred down, not an active infection, and hydrosalpinx, diverticulosis, and things like that. We can't justify doing 30 unnecessary laparotomies for every ovarian cancer that we pick up. So currently, the recommendation for screening is still annual pelvic exam, not ultrasound at this point. So we're going to do an ultrasound, chest X-ray, CA-125, CBC, liver function tests, chemistries. Ultrasound shows a 4-centimeter multicystic complex right adnexal mass. What kind of tumor does it sound like? Where you have multicystic. This is epithelial, right? It's more likely going to be a serous or a mucinous tumor. Chest X-ray, negative. CA-125, elevated. Blood tests, normal. So it sure sounds like ovarian cancer. How do we make the diagnosis? It's surgery. Exploratory laparotomy, multiple biopsies, collection of acidic fluid to see is it positive or negative. What do we find? Right ovarian papillary serous adenocarcinoma. Left ovary uninvolved, multiple 1-centimeter omental implants. What stage is this? 3. What is the most common stage at diagnosis of cervical cancer? 1. What's the most common stage at diagnosis of endometrial cancer? 1. What's the most common stage at diagnosis of ovarian cancer? 3. That's why it has the highest death rate of all gynecologic cancers, because the stage of diagnosis is late. Collection of acidic fluid, positive for carcinoma. See, what happens with ovarian cancer? Well, let's take just any cancer. Where does it usually spread to? The surrounding tissues. So you take endometrial cancer, what's adjacent to the endometrium? Myometrium. What's adjacent to the cervix? The vagina. Okay, and the endometrium. What's adjacent to the ovary? Nothing. It's hanging. It's hanging on the mesoovarium. So what happens to malignant cells? They drop off, go into the peritoneal fluid, and then where do they go? All over the place. Behind the liver, behind the spleen, the diaphragm. That's why when you operate, you have to take multiple biopsies all over the place. So, the management is TAH, BSO, total abdominal hysterectomy, bilateral salpingo-oophorectomy, omentectomy, because the omentum is the policeman of the abdomen. It says, if there's a problem, I'll take care of it. If there's tumor, it says, give it to me. Come into my waiting arms. That's what the omentum does. So we take out the omentum. If there are large tumor masses, we do a tumor debulking. Sometimes it's called cytoreductive debulking surgery. It used to be that when they would open up the postmenopausal woman and find cancer all over, they'd just close her up and say, send grandma home to die. There is now good evidence, if you take out as much of the tumor as possible, that you can actually increase survival. And I have one patient who's now 12 years down the road, and she had stage 3, and then chemotherapy. The outlook for this lady is not good. Not good. Okay. We're getting there, folks. Any questions on that? Ovarian cancer. What percentage of women will get ovarian cancer? 1%. So 1% of women. That's a lot of women in the United States. Okay, 57-year-old with a vulvar lesion. This is pretty straightforward. 57-year-old type 2 diabetic on oral hypoglycemic agents comes to your office complaining of vulvar itching for 6 months. What is the most common symptom of vulvar cancer? Usually no symptoms, but if there is, it's itching. What is the most common symptom of a benign vulvar lesion? Itching. You can't tell the difference between the two by symptoms. On examination, you find a 6 by 10 millimeter lesion of the left labia majora that is whitish in appearance and firm to palpation. If it's whitish in appearance, what do you think the histology will show? Hyperkeratosis, right? Hyperkeratosis. And if it is firm, it's probably going to be thick. Let's have a look and see what this is. Differential diagnosis: benign vulvar disease, vulvar dystrophy, vulvar carcinoma. What's vulvar dystrophy? This is a unique disease which is only seen in the vulva. It is not malignant, does not have premalignant potential, but it can look like and have symptoms similar to vulvar carcinoma. This is often known as hyperplastic dystrophy, or it can be lichen sclerosis. And you can't tell by looking. The diagnostic plan must start with biopsy. And it shows squamous hyperplasia. I'll show you a picture of what that looks like. The assessment: squamous hyperplasia, a benign lesion without malignant predisposition. And the treatment is fluorinated corticosteroid cream. So, the management of squamous hyperplasia is fluorinated corticosteroid cream. This is how you do a biopsy. You will inject the area with local anesthetic, use a punch biopsy, remove the specimen. If it's bleeding, you'll just go ahead and cut it off and perhaps put some silver nitrate on it. Just send it to pathology. You don't even need to do any suturing on there. But you've got to get a tissue diagnosis. This is squamous hyperplasia. Look at the thick keratin layer up on top here. And look at the thick rete pegs. This is what you treat with fluorinated corticosteroids. Another vulvar dystrophy is called lichen sclerosis. Look at how thin the epithelium is here. It used to be called lichen sclerosis et atrophicus. And the treatment for this is testosterone cream. And I think that's all you need to know for the exam. Hyperplasia, fluorinated corticosteroids, lichen sclerosis, testosterone cream. Now, if you have vulvar cancer, now we've got a whole different set of concerns. We have to do staging. We need to do inguinal node dissection, radical vulvectomy. This is a tough and difficult surgery. All right. Infertility. 28-year-old with 18 months of infertility. 28-year-old nulla gravida comes to the outpatient clinic 18 months of infertility. What are the diagnostic criteria for infertility? Inability to conceive with regular intercourse over what period of time? 1 year, 12 months. So she certainly met the criteria. What would you do on the exam if a couple came to see you after 6 months? Take their money and start the workup. See, even an adequately fertile couple, it will take 12 months before 90% will conceive. Now, of those who don't conceive within 12 months, you have basically a mixed bag. You have subfertile, who take a little bit more time, and you have those who are sterile. And you really don't know when you start out which is which in that group. But here she's got clearly 18 months. Menses are usually regular, lasting 4 days, occasionally skip periods. She's been treated with pelvic... the reason for this is, what are the causes of infertility? The three biggies are anovulation, male factor, semen, tubal disease. Okay, so here we've got a patient who has occasional skip periods. Could she be anovulatory? She's been treated for pelvic pain caused by STDs. Could she have tubal adhesions? Intercourse is regular, 1 to 2 times a week, no sexual dysfunction. Pelvic exam, normal vulva, perianal area, vagina and cervix without lesions. Clear, thin, watery cervical mucus. What does that suggest to you? Estrogen effect. Maybe she's anovulatory. Bimanual exam, symmetrical, mobile, nulliparous uterus. Mild right adnexal tenderness, no palpable masses, otherwise normal. All right, let's look at our infertility workup. The differential diagnosis we mentioned: anovulation, male factor, tubal disease. Those are the three biggies. Is there an egg? Anovulation. Is there enough sperm or adequate quality of sperm? And can the egg and the sperm meet? Basal body temperature will tell us, at least indirectly, is she ovulating. What would you like to see in an ovulatory patient on basal body temperature? You'd like to see mid-cycle rise. Progesterone effect on the thermogenic center of the brainstem. TSH and prolactin would give us some correctable causes of anovulation. Semen analysis. You know, it's one thing to say to a gentleman, if you would go into this room and please give us a urine specimen. It's another thing to say, would you just go in this room, please give us a semen specimen. You know, it's great to have sex when you feel like it. But when you're told to, this can be a troublesome time for many couples. Cervical cultures, GC and chlamydia. So what do we find? BBT, biphasic. Probably ovulatory. TSH and prolactin, normal. Semen analysis, looks okay. Cervical cultures, negative. What do we have left? Tubal disease. Primary infertility, probably due to tubal disease. What's our next step in management? Hysterosalpingogram. This is our screening test. Hysterosalpingogram. This is done in the proliferative phase after the period, because you don't want to do it if she could be pregnant. You inject into the uterus dye, which is radio opaque, either a water-based or oil-based. Each has their advantages. You would want to give the patient some NSAIDs to try to prevent any uterine cramping. Cover her with some antibiotics in case she has old PID, which you don't want to stir up. And then you take your X-ray. What do we find? Normal uterine cavity, but bilateral distal tubal occlusion. Next step in management. Shall we try to fix the tubes? Diagnostic laparoscopy. Possible lysis of adhesions. So that's basically it. The three causes of infertility which are most common: anovulation, semen, male factor, tubal disease. The easiest to assess is anovulation. either with a serum progesterone level, endometrial biopsy which shows secretory endometrium, or a basal body temperature chart. Semen analysis needs to be fresh after 2 to 3 days of abstinence. Need to examine it within 1 to 2 hours after ejaculation. Those would be your initial outpatient tests. Non-invasive. If those do not show, let's say she's anovulatory, how do you treat that? Clomiphene citrate. Okay, that would be easy. And the semen analysis depends on what you find. If you have decreased sperm count, then you might try intrauterine insemination. See, of the sperm that enter the cervix, how many make their way up into the uterus? It weeds out most of the sperm. So if you bypass that, that may be helpful. If there are just a few sperm that are viable, then you might try ICSI, intracytoplasmic sperm injection. Just inject one in. This is in vitro fertilization. And if there are no sperm, what are you stuck with? Artificial insemination by donor. So we check out ovulation, we check out the semen analysis. And if those look okay, then you do the hysterosalpingogram. If that's negative, then you have what is called unexplained infertility. Now what are you going to do? That's the kind where you say, I don't know what's going on, you probably won't conceive. So the couple adopts, and then what happens? Boom, get pregnant. We won't go into all of that. Okay, here's a basic workup. The invasive tests check out the semen. If it's okay, then you continue down. If it's not, intrauterine insemination, ICSI, artificial insemination by donor. Is she ovulating? No. Clomiphene citrate, Clomid. If that doesn't work, human menopausal gonadotropin. If she's ovulating, semen is okay, the next step is hysterosalpingogram. If that's not okay, if there are adhesions that you see, laparoscopy. If the hysterosalpingogram looks normal, then we call this unexplained infertility. Unexplained, it should be infertility. And here we will do intrauterine insemination anyway, and do ovarian hyperstimulation with clomiphene anyway. If these don't work, IVF. What does it cost for an IVF cycle? One cycle. $10,000. How many cycles are you going to plan on? Yeah, 3 to 4 cycles. That's money. Big money. Okay. Last case. Any questions on infertility? What percentage of couples are suffering from infertility, do you think? 15%, 10 to 15%. I imagine there's some of you.
Did you say the semen track is 2 to 3 days after? Is that example?
No. 2 to 3 days of abstinence. No ejaculation. No sex. Because you want to make sure you get everything primed up. Okay.
What is the best way to find out anovulation?
The best way is the serum progesterone level.
They ask in the exams.
Serum progesterone level. Because where is the site of progesterone? There's only 2 sites of progesterone production in the female. One is the placenta. The other is the corpus luteum. So if she has low levels of progesterone, she's not pregnant and she's not ovulating. So that's going to be probably your easy one to get. More expensive, however, than a basal body temperature. Okay, 17-year-old has never had a menstrual period. How common do you think this is? 1 to 2%, not very common. 17-year-old comes to the outpatient clinic with her mother, stating she's never had a menstrual period. Never. She's in good general health, is in her first year of university, 65 inches tall, 130 pounds. Appropriate weight? Sure. General examination shows normal adult pubic and axillary hair. What does that tell you? Pubic and axillary hair. She must have androgens. Females respond to androgens as do men in the formation of terminal hair. You have the vellus hair becomes terminal hair. Vellus hair is the kind of hair that women have on their cheeks usually. Terminal hair is what men have with a beard. What changes the vellus hair to terminal hair? androgens. So she's got androgen receptors. Is there a condition where there are no androgen receptors? What's that called? Androgen insensitivity. In this case, you would not see any axillary or pubic hair. So that's not the diagnosis here. Nextly, she has normal adult breast development and female body contours. What do we know hormonally about her in addition now? She's been exposed to estrogen. So her body is responding to estrogen. Breasts are an endogenous assay for estrogen. Pelvic exam reveals normal external genitalia, but a 1 centimeter long vagina. That's all. And no cervix. On rectal exam, you can't palpate a uterus. Differential diagnosis. Malarian agenesis. That's got to be the number one here. Complete androgen insensitivity. No. Breasts present, no uterus. The differential diagnosis is 2. Malarian agenesis, androgen insensitivity. Because she's got axillary and pubic hair, she couldn't have androgen sensitivity. Malarian agenesis, most likely. This is a artist's picture of a patient who has Malarian agenesis. Here we have the bladder. This is a rectosigmoid. Here are the ovaries, but where is the uterus? What are the derivatives of the Malarian system? The tubes, the corpus of the uterus, the cervix of the uterus, and the proximal vagina. So when those are absent, that's what you will see. Now here's a couple of girls who are sisters. They are genetic males. They have complete androgen insensitivity. But notice they have no pubic or axillary hair. That's what you find with complete androgen insensitivity. The diagnostic plan, pelvic sonogram to look to see is there any internal genitalia, serum testosterone, and karyotype. Pelvic ultrasound shows uterus absent, ovaries present. Serum testosterone, normal female levels. Karyotype, 46XX. What would you expect with androgen insensitivity on ultrasound? Would you see ovaries? There's no ovaries. Where are the gonads? Inguinal canal. The testes haven't descended. There's nothing to descend into. What will the serum testosterone level be with androgen sensitivity? Male levels, high. Karyotype, XY. Malarian agenesis is our assessment. Idiopathic, regression of Malarian derivatives. What happened? Where did they go? I don't know. Idiopathic. Management. Functional vagina can be created either surgically or using vaginal dilators, but does she need any hormones? Her FSH, her LH, her estrogen, her progesterone are functional, normal, going up and down, but they have no end organ, uterus, to respond. That's why you don't have the menses, but she doesn't need any hormones. How about with the androgen sensitivity? See, what are you going to have to do to treat her? You're going to take out the gonads. Why? Increased risk of malignancy. You take out the gonads, there's no more estrogen being produced. So now she's going to be at risk for estrogen deficiency. So now she needs estrogen. Does she need progestin? Why? No uterus. Doesn't need it. But this lady here, she doesn't need any. Now, this lady could have her own genetic children. But she would have ovarian stimulation, aspiration of the follicles, and then she'd have to find a woman who would be her surrogate mother, who would take them. But these are her biological children, but not her. She can't carry them herself. This is interesting. You can actually create a vagina by dissecting into the perineum, and this is a skin graft, which you can place in. And what is interesting is they've actually taken bowel, and the columnar epithelium of the bowel will undergo metaplasia into squamous epithelium, and she can have a normal functional vagina from that. Okay, let me just run this through, and then I think this will be the last slide. Primary amenorrhea. What I like to do, looking at this, is breast present or absent, uterus present or absent, and we'll divide these patients into two groups. What we just looked at was breast present, uterus absent. There's two differential diagnoses, and we will sort those out by serum testosterone level. If it is a normal testosterone level for a woman, the likelihood is it's Müllerian agenesis karyotype 46XX. If the testosterone level is high for a female, the diagnosis is probably androgen sensitivity, and you just diagnose or nail that diagnosis down with a karyotype 46XY. This woman will have no normal pubic and axillary hair. This woman will have no pubic and axillary hair. There's a well-known Hollywood actress, Jamie Lee Curtis. Now, she has a child, you know, but she adopted the child. It's not her own child. So this is the two diagnoses for breast present, uterus absent. Müllerian agenesis and complete androgen sensitivity. Now, don't tell her that she's a man. She thinks, she looks like a man, she functions as a female, I should say, even though her karyotype is going to be male. Now, then we have breast absent, uterus present. And this is primary infertility. Correction, primary amenorrhea. If breasts are absent, what do we know about estrogens? Low.
No.
Why are estrogens low? There's only two diagnoses. One is follicles are present but not being stimulated. The other is no follicles present. How do we differentiate between those? FSH level. If the FSH level is high, what's your diagnosis? Turner syndrome, gonadal dysgenesis, 45X. That's why she has no follicles in her ovaries. If the FSH is low, she has follicles, but they're not being stimulated. And this is a problem either with the hypothalamus or the pituitary or both. How can you check out which it is? If you give this patient GnRH and the FSH levels rise, where's the problem? In the hypothalamus. If you give this patient GnRH and FSH levels don't rise, where's the problem? In the anterior pituitary. This is a patient who needs to have a imaging of her CNS to make sure there isn't some sort of tumor which is going on there. So, primary amenorrhea, breast present, uterus absent, Müllerian agenesis, androgen sensitivity, breast absent, uterus present, gonadal dysgenesis, hypothalamic pituitary failure. This is my best slide coming up. I want you to listen to this. Okay.